So we are starting a new topic from therapeutic guidelines about orofacial pain. It is from page number 129. First, they are giving an overview of orofacial pain for the dentists. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So it is an unpleasant sensory where actual sensory receptors are damaged or they are about to be damaged. There is still a fight, an inflammation going on. So they have a potential also. It covers both scenarios, actual as well as potential tissue damage. And a greater part of the bearing of pain is also an emotional experience. Sometimes it is emotional part of it is far more powerful than the sensory part. So this whole is the definition by TG. Now, pain is a subjective experience influenced by both sensory inputs received by the brain. Example, in response to inflammation. So some inputs are being sent by the brain, and the brain's interpretation of these inputs in the context of other available information. So there is a past memory in the brain. So it files, that whole library of file of the pain opens up. If a person has not had pain previously, so there is an unpleasant stimulus and reaction to it. But there should be some context of previous information or other available information for this to be processed as pain. For example, a patient's pain experience may be influenced by their coping strategies, previous experiences with pain and pain relief, and their confidence in the clinician's ability to diagnose and manage their condition. So we have some people who are who can have maximize or amplify their pain experience. They are not able to for a minimum, say if we can measure the pain in 10 magnitude for some units, and the same two people are having 10 magnitude of pain, but their emotional response, their coping strategy would bring about the difference in experience of the pain and how the things move ahead. So just an example, I had this conversation with my husband. Day before yesterday, I dropped burning milk on my, just boiled milk on my hand. And then he counseled me. It was a very shrieking kind of a pain. I slept with that for about half an hour. I was keeping my hand in the chilled icy water, and after that this was like it was still paining, burning a lot. The internal tissue damage had just started. But what he mentioned is, I can think that I'm applying ice. Just the thought of application of ice can also cool the system. This is just in our kind of a self-relief. So instead of doing actual physical application, that counseling the mind or thinking or kind of affirming that it is being held there, cold stimulus we are applying can heal the pain. And yes, to an extent it worked. It needs a kind of a concentration over that injured part and trying to invest your energy in there. So it all depends upon various coping strategies. We have audio analgesia and various acupuncture, pressure therapies, which are the part of the alternative medicine to cure the pain. Now, orofacial pain has many causes, only some of which are dental. If the patient's pain is not of dental origin, refer them for medical assessment. So first of all, we have to analyze if teeth are fine. intraoral examination and the history has to be processed right. So what are non-odontogenic pain examples? Trigeminal neuralgia, sinusitis pain. They appear, they just mimic like dental pain. Some of the times patient is coming and telling you this tooth is aching. That is because the sensory nerve supply is blocked by the maxillary nerve. Upper molars as well as maxillary sinusitis can have the similar pain response. Trigeminal neuralgia, it pains, suddenly it starts. And irreversible pulpitis pain is almost a similar type. So one has to first rule out how we will rule out whether it's odontogenic versus non-odontogenic, confirm whether there is actual decay, actual periapical abscess with taking the x-rays, actual hypersensitivity, something intraorally should be there to say it is a painful thing. It's an odontogenic pain. And there have been cases where patients have undergone extractions. One of my colleagues told me that she was working in New Zealand. So there was one case, a patient came and got her all the teeth of one quadrant extracted because she was going through excruciating pain. And when she visited their clinic, the dentist there told her that it was maybe non-odontogenic in origin. She probably had trigeminal neuralgia. So this is the major assessment, and ADC is testing you whether you know the non-odontogenic and odontogenic difference of pain. The easiest way is you will have clinical findings on teeth in odontogenic pain. There will be radiographic assessment of that clinical finding, which will confirm that this is odontogenic pain. If the patient's pain is of dental origin, assess the type of pain, nociceptive, neuropathic, or nociplastic. So it is all dependent on the type of the nervous sensation, the sensory inputs being carried, and its duration, acute or chronic. Suddenly it is started, just patient have even reported just an hour back, the patient is coming to you with the painful cheeks and something. So this is how acute or chronic, we know if it has been long since present. Some patients will come and say it has been present for last 6 months. It has been present for last 3 months. So that is a chronic pain. Because of these factors, they affect the optimal treatment strategy. So we have to first assess odontogenic, non-odontogenic. Non-odontogenic, straightway refer for medical assessment. Odontogenic, we have to process further information, what type of pain, acute or chronic, and then devise come to actual treatment strategy. Now, what are the differences between the three terms they used? Nociceptive pain, neuropathic pain, and nociplastic pain. So first is nociceptive pain. It arises from activation of nociceptors, receptors in skin and deep tissues that are sensitive to potentially noxious stimuli due to threatened or actual tissue damage. Example, inflammation in irreversible pulpitis. So we have this actual irreversible pulpitis. It is actual receptors on the skin, mucous membrane, deep tissues. They are potentially exposed to noxious stimuli. And this is inflammation pain is all the nociceptive pain. Then we have neuropathic pain. It arises from injury or disease of the somatosensory nervous system. So we have this somatosensory nervous system, which is like somato means the body tissues and sensory is the sensory system. Now, nociceptive is actually receptors on skin, but it may not be actual deep tissues like stomach ache or anything. It's not a part of nociceptive pain. But neuropathic somatosensory, inside is, deeper tissues are involved in neuropathic. It is often described as a burning or tingling sensation. Oral neuropathic pain is not uncommon. That means it is common. Okay, if you read this word, break this word, not uncommon. It can be difficult to diagnose, and investigation by a dental specialists will be needed. Example, oral medicine specialist, oral surgeon, oral and maxillofacial surgeon may be required. So deep tissues damaged, maybe something, say salivary gland damage, or a deeper pain being carried by the maxillary nerve or a mandibular nerve. Then we have nociplastic pain. Usually, okay, neuropathic pain are usually like the pain which is damaged because of damage to the deeper tissues and deeper organs of the body. So they are more falling into neuropathic variety. Nociplastic pain, it is the diagnosis of exclusion. It is considered when nociceptive and neuropathic pain have been ruled out. In nociplastic pain, states central sensitization is the key contributor rather than ongoing pathology. So it is the rarer one. So if we are not able to classify it either between nociceptive and neuropathic, we would go into nociplastic one. And it's diagnosis of exclusion. Then we have pain managed by the dentists is usually acute dental pain. And such pain are what we are dealing mostly is the nociceptive pain, the first variant, okay, which is based on the free nerve endings, which are present on the mucosa, which are present in the pulp, which are irritated because of irreversible pulpitis. And even the kind of the pain because of an ulcer or because of any oral eruptions or anything, that painful sore mouth is also of nociceptive variant, because there also tissue damage is there, noxious stimuli is present. And this is all, we are broadly dealing with the nociceptive pain. Now, such pain is usually nociceptive, usually resolves rapidly with appropriate dental treatment, but may require short-term use of analgesics. It serves as a protective biological function. It alerts the body to a potential threat, prevents the body from further harm, and can teach the body to avoid similar harm in the future. So we have, this is a, like it is well explanatory, that protective biological function. So for example, when you see a red flag lesion, okay, these kind of lesions we are not able to identify earlier. You would see in the cigarette packets, like the whole of the mouth being compromised because of a lesion. That was not creating the pain initially. The patient kept on living with it even after it started maybe as a ulcer on the tongue. Because it was not painful, it went neglected. And it was giving sensation loss, okay? The nerve fibers were dying in that case. So in that sense, it didn't serve as a protective biological function. Human being is very, very reactive to pain. So if it pains, we run for a treatment. Otherwise, we keep living and lingering about it. So that's how this is, tooth pain is actually a signal by the tooth that treat me now. And the patient rushes usually for RCT, and that is the treatment plan, RCT or extraction if it is odontogenic pain. Then we have chronic pain, also referred to as persistent pain. It may be associated with ongoing pathology. However, often the originating pathology is no longer evident, and pain persists because of lasting changes within the nervous system. So this is, some pathology is happening, chronic variant of the pain. Suppose pain is, it can be reversible pulpitis, which is started 3-6 months back. So pathology is slowly growing in these cases. And pain persists because of lasting changes within the nervous system. And such pain may be nociceptive, neuropathic, nociplastic, or mixed. So it can be any of the combination also. It can be difficult to diagnose because there may or may not be any obvious pathology. It may result in anxiety, fear, depression, loss of sleep, and impaired social functioning. These factors may also affect a patient's pain experience, right? So all these factors, the emotional bearing can amplify the pain. It requires socio-psychobiological chronic pains like TMJ pain. Those who have it, it's a chronic pain. Joint pains are chronic pains. So they require socio-psychobiological approach. It is, or chronic pains like backache, other example from the dental if we go. So, and it is musculoskeletal pains are usually of the chronic variety, and they need more approaches. Just analgesics have a limited role. Okay, analgesics as a principle, if I can say, they can work to reduce inflammation. They are working on the lines of reducing the inflammation part. So we have this zone where it is muscles or skeleton system is sore or something. Biological approach, social approach might be needed. Causes of chronic orofacial pain include temporomandibular disorders, as I mentioned just now, and burning mouth syndrome. So burning mouth syndrome, which we read in the previous, where whole of the mouth is having typical presentation of burning-like symptoms. Then in a patient with chronic orofacial pain, if a patient with chronic orofacial pain presents with dental pain, determine whether the pain is a symptom of their chronic pain condition or associated with dental pain pathology. So you have to identify whether this pain is in itself a chronic pain condition. Okay, for example, temporomandibular disorder is a chronic pain condition by itself. Okay, it is not a result of dental tissue damage. Okay, over musculature, those people who get myofascial pain dysfunction syndrome, there is no inflammation per se. The muscles are just tired and they are aching. Okay, something like if you run a lot on first day of starting exercise, this is at some level muscles are fatigued. Okay, so we would not say they have become inflamed per se. So that's how we differentiate between whether it's a chronic orofacial pain, which is the pain in itself, the cause is manifesting as pain, or whether it is a dental pathology which is exhibiting as pain, like reversible or irreversible pulpitis. Do not undertake dental treatment unless a dental pathology is confirmed to be causing the pain. Like I gave the example of this trigeminal neuralgia lady whose all teeth were extracted because she was thought to be having pain from this tooth, that tooth, and likewise. So we say that do not undertake dental treatment unless dental pathology is confirmed to be causing that pain. Then we have acute dental pain. Acute dental pain is usually inflammatory in nature. We will go from the table ahead and outlines common causes. Okay, we will read the common causes of the acute dental pain and also consider conditions that are less common, difficult to diagnose, or not of dental origin. So acute dental pain, odontogenic causes, plus, for example, trigeminal neuralgia, which may be mistaken for pulpitis. Refer patients for medical assessment if orofacial pain is not of dental origin. And they are saying this, that dental treatment is the most effective means of managing acute pain of teeth or surrounding tissues. Drug therapy has more limited role and should only be used if necessary. So start the dental treatment. Do not put the patient on painkillers and linger the treatment on. Dental treatment, they have again highlighted, is the most effective means of reducing pain of teeth and surrounding tissues. So they build up the MCQs like this, that a patient came with a painful 1-6, you did the investigations, found out that the patient is having irreversible pulpitis, and the patient is not is on tight schedule. How would you manage the pain? So you would one option would be prescribe the painkiller and recall for RCT. Other example would be you do emergency access opening and further the treatment in the next visit. You would prescribe, say, caffeine and some ibuprofen or something. So they would be options, but the best treatment option is dental treatment is the most effective means of reducing pain of the teeth and the surrounding tissues. You do not give treatment by just prescribing analgesics, but yes, they are an important pain alleviating treatment which is adjunct to actual dental treatment. Then we have this table. What are the causes of pain? Okay. So first is description of pain and associated features. Intermittent dental pain that is experienced when the tooth is exposed to a stimulus, example, hot, cold, or sweet food or drinks, and resolves once the stimulus is removed. Okay, so this is the pain happens on a stimulus and it subsides once the stimulus is removed. It is intermittent in nature, so most likely causes reversible pulpitis because it reverses back to health when the stimulus is not present. Initial management by medical practitioners. If the patient is visiting medical practitioner for his toothache, sometimes there is non-availability, or the patient is from a background who doesn't know between a dentist and a rural background or completely typical primary healthcare centers, that kind of a thing. So initial management can be done by medical practitioners, that is prescribing analgesics or something. Advise the patient to avoid food or drink that provoke the pain. Cover any obvious cavity with an inert material like chewing gum or blue tack. This is done by medical practitioners. This is not for the dentists. So ADC is not testing you as a provider to put inert material like chewing gum, blue tack in there. Unless and until there is something in the stem which says that you do not have much options to start treatment. Advise the patient to see dentist as soon as possible, and analgesics and antibiotic therapy are not indicated. So clearly here they have written it is not indicated for reversible pulpitis treatment. Okay, analgesics, antibiotic therapy not indicated. Dental treatment. Simple restoration or desensitization treatment is needed. So you are not starting any pulp procedure because it is reversible pulpitis. Reversible pulpitis, we have to be least invasive. We are not cutting the pulp. We are just creating or covering that cavity with a restorative material. The food will not get lodged there. It will provide relief from the pain. The pain fibers will not get scintillated again and again. So that is the dental treatment. So very important point in reversible pulpitis. Analgesics, antibiotic therapy not indicated. Simple restoration or desensitization treatment is the one which is required. Then we have severe dental pain that is experienced when the tooth is exposed to a stimulus, example, hot, cold, or sweet food or drinks. So it is a severe dental pain. And the pain persists as a dull throbbing ache even after the stimulus is removed and can become continuous. So it can start by something and still persist even that food stimulus is removed, even after that food stimulus is removed. Or it can start as a spontaneous pain by itself. Suddenly it's starting. That also can be irreversible pulpitis. Then we have likely cause irreversible pulpitis, initial management by medical practitioners. Again, these three things remain the same. Not to eat food or drink that provokes pain. Here, what medical practitioners is giving, offer analgesics, NSAIDs are preferred if the patient can use them. If the patient can use them means if the patient is not having renal condition, if not having liver conditions, which are, compromising the safe use of NSAIDs. Cover any obvious cavity with chewing gum or blue tack. And if symptoms are severe, consider giving LA of the affected tooth for temporary pain relief. And for information, okay, we would read about anesthetics again. Advise the patient to see dentist as soon as possible, and antibiotic therapy is not indicated. So in reversible pulpitis, analgesics, antibiotic, both were not indicated. In irreversible pulpitis, antibiotic therapy only is not indicated. A primary care provider, a medical practitioner can still offer analgesics to patients in this. Dental treatment, endodontic treatment, root canal or extraction is the only solution. Once it's irreversibly damaged pulp, only two ways are possible. Either remove the pulp system, which is the life or nerve of the tissues, or remove the whole of the tooth in itself. Next, dental pain that presents as a dull throbbing ache and not triggered by a stimulus such as hot, cold, or sweet food or drinks. Tooth may be sore to bite on. So this is, it is not triggered by a stimulus. Okay. Hot, cold, or sweet food or drinks is not triggering it, but it is continuous, dull, throbbing kind of a pain, and tooth may be sore to bite on. So this can be apical periodontitis, infected root canal system with acute periapical inflammation. So in irreversible pulpitis, the whole pulp was irreversibly damaged, but it had not created any periapical radiolucency. It did not, our inflammation has not percolated, penetrated the apex of the tooth, which has happened in this case. So here it is, we have periapical abscess below the, this is apical periodontitis. It has more dull throbbing and periapical radiolucency on the X-ray will be there. Antibiotic therapy is here also not indicated, which is for a localized odontogenic infection. However, if dental treatment is not likely to be received for 24 hours, say there is a delay in getting the patient with more treatment, we would be starting antibiotic therapy. Okay, so we have this. Start antibiotic therapy if the patient is not reaching dentist within 24 hours. As for spreading odontogenic infection without severe or systemic features, which we have read before, there are three types of odontogenic infection. One is localized odontogenic infection where just the tooth is involved, surroundings are clear. Next is odontogenic infection, which is spreading variety, but systemic features are not present. That is, pain is, the fever is not there, lymphadenopathy is not there. The third variant is spreading odontogenic infection without, third is with severe systemic features, which is having fever, tachycardia, lymphadenopathy. So here we have to start antibiotic therapy if the patient is not reaching a dentist within 24 hours. Because in this, if the patient makes a delay, what would happen? It's already apical periodontitis, right? So it will become localized infection. So we have to halt that spreading of infection. And the last is tenderness of the tooth to pressure on biting. And the likely cause in this case, let me clear this drawing. This is the likely cause, fractured or cracked tooth. How is the pain like? Tenderness of the tooth to pressure and on biting. The patient says that my tooth aches when I just bite. So when the patient is saying biting ache, fractured or cracked tooth, or localized odontogenic infection, initial management by medical practitioners would be advise the patient to see dentist urgently. It is difficult for medical practitioners to differentiate a fractured tooth from a localized odontogenic infection, even with imaging, without visible abscess or pus or to indicate infection. Offer analgesics to the patients. NSAIDs are preferred if the patient can use them. And antibiotic therapy is only indicated if, again, the patient is not able to see dentist within 24 hours. Then we have dental treatment, restoration, endodontic treatment, root canal or extraction is needed. So in this, depending upon what kind of crack it is, whether it is a through and through crack, or we can manage with just upper crown portion is partly cracked. So it can be managed with restoration, or it can be managed with endodontic treatment, or versus if it's like a vertical fracture of the tooth or the root, involving the root, then especially it will go for extraction. So we have some of these treatment options for fractured or cracked tooth. Now, what is the difference between fractured and a cracked tooth? Cracked tooth is like there is a crack running, but it is not separated. For example, we have these smart glasses where if they fall, there will be a crack, but they do not chip off. So that is the cracked tooth. Fractured is when there is separation between the two segments, or maybe obvious loss of one segment, like mesioincisal fracture of the part of the incisor. So that is fracture. Okay, we have another two types of pain, which are even discussed before. If the patient has facial swelling and pain following a toothache without any of the following, like if the patient does not have significant facial swelling and pain, trismus, neck swelling, difficulty swallowing, difficulty breathing, airway compromise, or systemic features of infection. So it is spreading odontogenic infection without severe or systemic features. In this, what will medical practitioner do? He will prescribe analgesics. If dental treatment not likely, antibiotic therapy will be started and urgent visit to dentist. Dental treatment, endodontic treatment or extraction, because now it is an abscess. It's a spreading odontogenic infection. And last, we have spreading odontogenic infection with severe or systemic features. Swelling and pain of a toothache with any of the following. So there is all the features which we discussed were not present before, all are present. Here, medical practitioners will provide appropriate support of airway breathing circulation, arrange urgent transfer to hospital. Here they are not sending to dentist, with oral and maxillofacial surgeon or other expert. And dental treatment would be surgical intervention with IV antibiotic therapy. So it is not done with oral analgesics. Here we give IV antibiotic therapy, surgical intervention, mostly it would be extraction, because it's an abscess, it's spreading, involving the system also. That's why urgent care needed. The patient can actually collapse because of breathing being impacted, and this infection can spread within an hour. So patient is advised not to lie down when it is a spreading infection.